This video is called Low BP, a closer look. A lot of what we discuss in this video is going to be kind of drawing upon material we've either covered or are about to cover in INP4 or variations for. Think of this more as a tool to help you get your notes together and your thoughts together on these topics, but really kind of taking out bits and pieces to really take a closer look at low BP, which is a really common clinical finding, whether we're in a medical setting or a surgical setting. So we're going to be discussing basically four major issues that are fairly common in terms of what underlies or what could possibly be underlying or foundational to the low BP that we're finding on the patient. And it's these four here: opioids, anesthetics, which I'm going to summarize for purposes of this video as meds. So meds could be an issue causing low BP, especially these meds. Of course, we could include BP meds as well on that, but that's fairly intuitive, and I don't think we need to bring that up right now. But, dehydration, very common, blood loss, and sepsis. We cover a few other topics in the area of shock unit of variations 4, but part of the purpose of this video is to draw upon these points to get us ready for integration testing. There are other relevant points in the shock class, but again, we're really trying to get the basic nuts and bolts to get us up and running for integration. And we'll expect a little bit more of a comprehensive understanding once we get to the variations, or if we've already written wherever we're at in the courses, the final variations exam will probably demand a little bit more information than this. But this is more of a functional video. Okay. So 3 categories here to look at for each underlying issue. So we start with physical signs and symptoms because it makes the most sense. That's what you're going to see on the patient when you're in the patient room. So let's start with that. And let's just talk generally first here for a second. Just low BP. What do we generally see as signs and symptoms on the patient? Well, let's just take a real quick look at this little person here. If we work our way from head to toe and we think of generic low BP. So again, we're not really focusing on any one of those underlying causes yet. We're just looking generically. What could we possibly find with any of those? We start at the top. We're going to find potentially, all these are all potentials, right? Lightheadedness, dizziness, confusion, tiredness, possibly a headache, although I have to say that usually comes a little more so with high BP, but it's possible. We often hear people saying I have a headache when they're dehydrated. So working our way down. With low BP, we might find increased resp rate. The body's trying to get more oxygen. It doesn't understand why there's not enough oxygen to the cells. So it's automatic that the resp rates increase. Maybe they become more shallow because they're more rapid. In terms of cardiovascular, we may expect, depending again on what's causing the low BP. We don't talk about every cause in this video. For example, if it's a neurogenic cause, which we talk about in shock class, then we may expect the heart to be slowed down. But let's put that on the side right now because we're not going into that topic today. For generic low BP from any of the 4 causes mentioned at the beginning of this video, it's quite possible you could find an increase in heart rate. Although I have to say with narcotics, you might, and anesthetics, you might actually find a decrease in heart rate too. But generally speaking, when we're talking about blood loss, dehydration, sepsis, it's quite likely that early on we're finding an increased heart rate. And then indeed, that's what we find a lot of the time in clinical setting, at least early on, before decompensation. And cardiovascular system is always, we might find coolness from the drop in BP. We might find a greater than 3-second cap refill. You might find weaker pulses down at the extremities, thready, they may call it, or weak. Moving down to GI, if blood pressure is low enough, we're going to find a decreased bowel sounds. Because when blood pressure is low and perfusion is low, the body shunts blood away to areas of the body that need it. The priority areas, like the lungs, like the brain. GI just doesn't count in that. And so less blood flow means less cellular action, means less peristalsis, means decreased bowel sounds, possibly constipation, but that's really not going to be at the top of our list right now. Decreased bowel sounds is probably what we'll find right away. Moving to GU, obviously decreased urine output. Now, if we look at some of the causes, not all of them, but some of the causes of low BP, things like sepsis, quick review, the thing about sepsis, or preview, depending on where you're at with your material, the deal with sepsis is it is a systemic inflammatory response, typically as a reaction to some infectious organism. So it's systemic inflammation, which causes vasodilation, dramatic vasodilation, which of course causes a drop in BP, but also enables fluid to move to tissues. And so that's the physiology behind the drop in BP with sepsis, but also explains why with sepsis we may find some edema in the extremities, as well as potentially some crackles in the lungs. Another change in vital signs that we may see with sepsis, and we've talked about all all four underlying causes of low BP in terms of likely higher heart rate coupled with that lower BP, higher respiration rate. Depending on the efficiency of that ventilation, we may find a lowered SpO2. With sepsis, we need to add in another vital sign that's going to stand out, and that's temperature. And for reasons which we'll kind of get into, well, I can say them right now, because the bacteria sometimes gets into the hypothalamus, we could find temperatures either elevated, which is a very common response to infection. So temperatures like that 38 or higher is usually indicative of needing a workup for sepsis or infection. That's a natural body response to raise the temperature, or it could be the bacteria raising the temperature too. But also what's unique about the sepsis is that that effect it has on the hypothalamus might actually cause a profound drop in a drop in temperature. So you may find temperatures hovering around 35 or lower. With the right context, that could be a sign of sepsis as well. So next we move on to what kind of lab results would we find for each of these. I'm just going to kind of skim over most of them and really want to spend some time with sepsis. In fact, what I'm going to do is really use the sepsis labs to kind of maybe talk about each of these. And you'll see what I mean in a minute. I'm going to pull the graph up that comes out, or the table up that comes out of your sepsis chapter or your shock chapter in the 4th edition of Lewis. So before I do that, let's just kind of talk a little bit about labs here. and interventions for each before we get to sepsis, because sepsis is, and we might tease out some fine nuances of these other ones if they come up in sepsis, but these ones should be pretty quick right now if we just do them right now. So if we talk about labs for opioids and anesthetics causing a drop in blood pressure from that kind of sympathetic system that's being dampened, to be honest, for lab results, really can't really think of any direct lab results that may come up. Yeah, you might have some secondary lab results come up. What do I mean by that? I mean, the drop in blood pressure for any of these. Okay, so now I'm talking for anything that drops blood pressure. You may find some global things like a decreased GFR, and then coupled with an increased creatinine and an increased urea. So that's what I mean by these things are fairly global with any drop in blood pressure. Other than that, what's unique to anesthetics or opioids causing drop in BP, nothing really comes to mind right now. In terms of interventions, if this is really the only thing causing the drop in blood pressure, the meds, and if respiration rates and level of consciousness is not decreased, then usually all we really need to do is give IV fluids. And that's usually what's being done anyways when these guys are getting these meds. And that'll bump up the blood pressure, should solve the problem. Now, of course, if the opioids or anesthetics are actually affecting level of consciousness or rest rate, then we just have to pull back on them altogether anyways. And that might have an effect. But generally speaking, 90% of the time, we've got rest rate and LOCs just fine, minus the compensation for drop in blood pressure, of course. All we need to do is give some IV fluids. Okay, so we've kind of more or less put this one away for now. Dehydration, really, you want to look at dehydration, you should be looking back at the first class we did in variations 4. And again, we might touch on a little bit of this again when we get to sepsis, but just in case we don't, remember, in addition to global things like your renal panel with GFR, we're talking about things classically like elevated sodium. But then we have to think about, well, what about if ADH kicks in, antidiuretic hormone? Well, then maybe sodium won't be so dilute. Once that kicks in and compensation happens, then sodium might not be quite so high. Aldosterone is another hormone that comes in and might cause sodium to be retained. So that might be a transient elevation in sodium until enough water is pulled back and held back by the kidneys, re-enters the vascular space, and then we might not notice an increase in sodium. Of course, if aldosterone is what's going on here with dehydration as a compensatory mechanism, that hormone, as you know, also causes K to be excreted. In fact, I'll say this right now, it's quite possible with any of these, if blood pressure is low enough, ADH and aldosterone is going to kick in, which again could have that similar effect on sodium or potassium for any of these. So it's kind of another global thing. In terms of interventions, if it's only dehydration that's the issue, you know the answer to that. It's IV and or oral fluids. So we can kind of put that one away for now. Blood loss, pretty much well, all of the above, except of course you want to add in our CBCs. Your hematocrit, your hemoglobin, and your red blood cells. Other than that, we've kind of said it all. But let me say something about this. Like I said a million times before, if you find someone on the street who's just bleeding out and no interventions have been done, as in no IV fluids started, sure, they may have a low blood pressure. Sure, they might be going in and out of consciousness. But when you take their blood work, if you did that on the street, which would be a very strange thing to do, but if you did, you actually would not find a drop in red blood cells or hemoglobin or hematocrit, because they're losing whole blood and we're not replacing it with anything. So the concentration of everything stays the same. Has their overall blood volume dropped? Yes, it has. And that's reflected in the signs and symptoms you're seeing as we listed here. And that's reflected in the fact that they are have a low blood pressure, but the blood work may remain unaffected until aldosterone or ADH kicks in. Once they kick in, the body struggles to retain water, and that water retention could cause, just like an IV fluid that we give people after surgery, can cause hemodilution. And that's when we start to see the drop in hematocrit, RBCs, and hemoglobin. Now, that might take a while to sink in. You need to think about that one. There's nothing more I can really say about it. You need to really ponder that, because that'll bring about a lot of understanding about what we see when we're in the hospital. For example, when people are getting IVs after surgery. Interventions. Well, this is an interesting one. I'm going to give you kind of middle of the road anecdotal interventions here. In other words, based on experience. It kind of goes like this. Hemoglobin may be low. Okay, and that's, although we look at hemoglobin, hematocrit, and RBCs, we always measure all three. When it comes to really looking at how we want to treat the patient, hemoglobin, for whatever reason, is really the one we look at and really, speak about the most, just, FYI. So hemoglobin could be quite low on a patient, but if they're alert, oriented, and other than maybe being a little bit tired, functioning in an alert and oriented fashion, I can tell you right now that the prescriber is probably going to want to opt for just IV fluids to bump up the blood pressure, and let the body, let the iron stores and the folic acids and the B12s and all that stuff, let that regenerate the blood cells slowly and naturally, the red blood cells. The big indicator, whether someone needs a blood transfusion or not, is signs and symptoms. Back to here. For example, if that patient's if that patient is really drowsy or really weak because of the loss of RBCs, and we maybe have tried to give IV fluids, we've even managed to bump up the blood pressure, but they're still anemic. They're, in this case, anemic secondary to blood loss. So if we bump up the blood pressure and they're still showing signs and symptoms of anemia, I'm not talking about lab work, because when it comes to blood loss, lab work is important. But guess what? It takes a backseat compared to physical signs and symptoms. You'd be surprised how many people are walking around right around you today, right now, who have a hemoglobin level of like 80, which in a textbook is way below what it should be, and they're functioning just fine. So I can tell you the lab work's important in the hospital, but the number one issue that's going to determine whether they get blood or not is the symptoms. Okay, so I think we can put that away for now. And it brings us to our last topic here, which is sepsis. And for that, we're going to look at some of the tables from your book. We'll talk about those tables, and that'll conclude our discussion on low blood pressure for now. So likely, depending on how we've set up the Moodle shell this time around, but likely you're going to find these tables in the shock section of your variations 4 Moodle, because that's really where we get into it in terms of shock, is in variations 4, but likely you're going to find these reference tables in that section. But in all fairness, you should have the textbook anyway, so you're going to find them in your textbook. That being said, you're going to be able to take a look at them right now too on this video. So let's look at some of these. So let's just kind of take a step back and let's just kind of, we're really focusing on sepsis a little bit here as one of our 4 underlying causes for drop in BP. Now, I mean, there's others we can add to the list. There's anaphylaxis, there's neurogenic, these topics, for example, we go into when we talk about shock. We don't need to talk about it right now for integration because, to be quite honest, yes, anaphylaxis, of course it happens, but actually it's really not that common. Um, and we'll talk about it when we talk about it in variations 4. But the reason why sepsis has a specific focus here, really crossing heavily over into INP4 this time around, is because sepsis is there's a much greater risk for that for all patients, and it actually happens quite a bit in the hospital. And it's not quite as obvious as anaphylaxis. Anaphylaxis can be scary, but it's pretty obvious when it's happening. Sepsis takes a slow approach sometimes to rear its head. And by the time it does, if it hasn't been dealt with, your chances of patient mortality go way up. 10% every hour that sepsis is untreated. Okay, so anyways, let's get into it here. Some diagnostics. And there's a bit of a mashup here. It's from the textbook, but it's a bit of a mashup here. I mean, it's talking about physical signs and symptoms here, which is what we kind of already talked about. You can read here the mental status we talked about. We talked about temperature, heart rate, we've already talked about. Hyperglycemia, which is fairly common in a stress response. And remember, we said temperature might be a bit low for reasons already discussed. Edema, the reason for that, we've already talked about, and increased rest rate. So in terms of general variables, we've kind of talked about them all earlier, even in this video. So the inflammatory variables, a lot of this comes down to blood work, elevated C-reactive protein, CRP. You actually might, I want to add to here, that's the most common test they'll do, but you actually might find, if the doc wants to test it, increased TNF, tumor necrosis factor. And you actually, and also ESR, erythrocyte sedimentation rate. So ESR, CRP, and TNF are all inflammatory markers that could be elevated. That being said, CRP is the most common non-specific. It just says there's increased inflammation in the body. It's the most common biomarker that the docs ask for. So CRP would be elevated. We don't really go into this one here in this course, the calcitonin. Really important here, increased white blood cell count greater than 12 for obvious reasons. It's infection and the body's trying to fight it off. And so that's no one of these, okay, I want to be really clear here. No one of these alone says sepsis. You typically have to have 3 or more before the hospital is really going to get into it and do a sepsis workup, so to speak. The only one that stands alone that's really going to get the attention of people of, oh, is there sepsis going on here, is the temp. Like if that comes up alone, a temperature greater than 38, that usually gets people's attentions, and we're usually doing blood cultures and that kind of stuff. But even that needs context, but that will get attention. But like a white blood cell count greater than 12, I mean, I've seen people come out of surgery with white blood cell counts of like 15, and they don't have sepsis. It's actually the inflammatory response to trauma of surgery. But that being said, they do check around for sepsis. They're doing the workups. But again, none of these alone mean that you have sepsis. You have to have a combination of things here, and usually it's 3 or more before they really dig into it. And then because the bacteria can also depress bone marrow functioning, you could also have a really low white blood cell count. So white blood cell count could be really elevated, greater than 12, or really low, less than 4 in sepsis. And this is just, yeah, we don't really get into this last one here, so don't worry about that. We've already talked about hypotension. And we've talked about how it might affect different organs. We've talked about the oliguria already. We've talked about, I mean, yes, of course, if they're resping inefficiently, then you get the blood gases could be affected. Coagulation abnormalities, yeah, I mean, because in sepsis, because of a phenomenon called disseminated intravascular coagulation, DIC, which we get into in variations. But long story short, clots form all over the body in severe sepsis. It can happen. And this causes coagulation factors and platelets to be used up. So you have these clots everywhere. So risk of clotting problems in limbs, in lungs, strokes, all that's a big risk. But at the same time, all of our coagulation factors have been used up. So our bleeding time goes up, our INR and PTT go up, but yet so does our clotting. So our D-dimer tests, which tests, to see if there's clots in the body, could also be elevated or positive. So it's profound what you might find is sepsis on those ones. We don't really go into the bilirubin ileus. We talked about why that could be. Creatinine we've talked about, and the platelet count goes down because, again, those platelets are being used for clot formation. Now, it's possible you could have someone who's septic who has an increased platelet count because that trauma and infection can also cause increase in platelets. So again, you don't have all of these with sepsis, but you could have some of them or a few of them, or all, if you're really unlucky. As we'll see when we look at lab work, actually, lactate can go up with any kind of low blood pressure. Any of those blood pressures can cause high lactate because low blood pressure equals low perfusion, equals low nutrient and oxygen being delivered to cells, so not enough oxygen or nutrients. That causes anaerobic metabolism, which byproduct is lactate, which is acidic, but lactate levels go up for any of them, including sepsis. So just looking at some of the diagnostic studies, this is for shock in general. So it covers more than sepsis, but just kind of, and I'm not going to necessarily go through every single one. I think you can read through these yourself, and based on what we've discussed so far today and in all courses, it's not too much to ask. I don't feel like I need to go through every single item here. But let's just look at some of them. So ABGs, arterial blood gases. Again, I mean, what's going on? It depends what's going on. Let's just talk about two examples. One is if there's anything that's causing hyperventilation, and low blood pressure can cause hyperventilation, then that could cause CO2 to be lost from the body, and that could cause alkalosis. As it says here, an early shock occurs secondary to hyperventilation. Okay, so it's possible. And again, guys, these are not all guarantees. These are just possibilities. You have to look at context. Okay, you have to look at what are the signs and symptoms that I'm seeing and what is the background and context. These are just possibilities. They're not guarantees of what's going to happen. But metabolic acidosis comes much more intuitively to anyone with a low BP, including sepsis, for what we just discussed, because low perfusion equals anaerobic metabolism happening, equals lactate byproduct, equals an acidotic environment. Don't worry about base deficit. Forget it. Blood cultures, you need them, right? If you suspect sepsis. We've already talked about BUN. We talked about creatinine kinase. I mean, this just depends what's going on. This could happen to any patient who's laying in bed for too long. You get muscle wasting, muscle breakdown. Creatinine kinase can go up. But that's kind of really neither here nor there right now. DIC we've talked about. This is the whole crazy thing about clotting and bleeding risk that happens all at once with advanced or later stage or severe, however you want to state it, sepsis. Glucose we've talked about, lactic acid we've talked about. Liver enzymes, sure, they can increase with any kind of shock. How's that? Well, the liver is actually not a huge priority when it comes to life or limb. So it doesn't get the blood it needs, cells start to die. When they die, they release liver enzymes. So that could go up. Potassium could be increased or decreased. It really depends on what's going on. If there's lots of cells dying for some reason, it gets released into the bloodstream. Okay, if it's a highly acidic environment, it gets switched out with hydrogen, C class 1 of variations 4. If there's lots of aldosterone, it could be decreased, as it says here. So all of these are possibilities. Maybe you got a guy going into shock, though, who's your GI patient who's been vomiting all day. Well, there's your reason for your low potassium. So guys, you got to understand this stuff. If you're trying to memorize it, you're done forget it. You got to understand this stuff so that you can look at a situation and see context. Okay, so like you're allowed to bring this into integration with you, for example, but it's useless to you if you don't actually understand it. If you're just guessing at it, we're going to ask you why. Why is that? Why do you think that's high? Why do you think that's low? And you're going to use context to try and figure it out. Talked about our CBCs already. Sodium, we've talked about. Troponin, well, I mean, hey, again, you drop blood pressure enough and you're going to have some cardiac issues, and that could cause cardiac damage. Now it's going to release cardiac enzymes, otherwise known as troponin. So we did make it through the whole list. That's impressive. So serum gravity, we might as well say it, the last one. This really, is a common one for dehydration. So if you take the water content out of the bloodstream, which is dehydration, or if you have sepsis and you're losing fluid portion into tissues, that leaves you with a more concentrated fluid in your blood vessels. And that's reflected in the urine that's put out. It's much more highly concentrated. And you guys know this. When someone's dehydrated, their urine is really yellow. It's concentrated. And if they measure the specific gravity of solutes in there, it's higher because it's more concentrated. Why does it occur secondary to ADH? Because when ADH kicks in, what happens? The kidneys are trying to move fluid back into the body. And so that what actually gets excreted as urine is even more concentrated. Okay, well, that leaves us with the last column. We've already talked about interventions for the first three. For sepsis, I'm going to simply default back to a case that is, for now, that's what we're going to do. And we'll hold you to this much only when it comes to integration, because we're going to default back to a case we talked about. Most likely, if we talked about it, it was in the emergency day. And let me just show you that one. It was a case that looked like this. And certainly now, after this little discussion, we can easily expect you guys to be able to discuss all these and more. Not have them memorized. That's not it here, guys. Don't try to memorize. That's not the time for that. This is the time for understanding and being able to discuss. So that's how you should be studying as well. Really testing yourselves. So there's that part. And then there was, what do we anticipate being ordered? That's the part we're at here. While you're in the room, nursing interventions, sure, there's things you can do, which again are in here. Sit your patient up, get a deep breathing cough, try and help their ventilation, maybe apply oxygen, all that kind of stuff. Keep them safe. If you think they're crashing, you may have to call a code. But the real thrust of that column of what are the interventions is kind of about, what kind of prescribing interventions are we going to need? Now, we talked about three of those things: blood loss, dehydration, and the side effects of medications. For sepsis, there's some similarities and some unique things too. We might need more blood work. And all these now, again, are things you can explain. We might need antibiotics if it's sepsis. But included in that blood work, of course, would be blood cultures. So until we get the results of those blood cultures, which would be STAT, we'd use a broad spectrum antibiotic. And then once we get the blood cultures, we'd correct as needed. Number three, fluid resuscitation. Until we get things back in order, we're going to boost with fluids. You might see all of these things up on the ward. But if they're bad, rough enough shape, they're probably going to be down in the ICU, where they're also going to use vasopressors to shunt blood away from the extremities back to the core organs. And in some cases, they might use a small dose of corticosteroids, but as I said earlier, they haven't been really shown to be universally a good choice for sepsis, not so much. although that's counterintuitive for what we've learned so far, but that's just sometimes science trumps our common sense. And science has shown that corticosteroids are not a great choice for sepsis, even though you'd think they would be, because, hey, sepsis is an immune response, it's dampening the immune system. Again, studies and real life experience have shown that it hasn't had great effects and has actually had some negative side effects. But they might still try it in small doses. But generally speaking, if they're really battling to get under control of these three, then they're going to move to this fourth one. So that kind of concludes what we want to talk about in terms of doing a little meditation here on low BP. So this grid here should be up on your Moodle shells. And I challenge you to start trying to fill it in yourself if you haven't already. But even if you have, try and do it again later by memory and test yourselves and make sure you understand what you're putting in there and why.